Good morning, guys. Today we're gonna speak about one of the diseases that cause restrictive lung disorder, and it's fall under the category of granulomatous interstitial diseases. We are going to talk about sarcoidosis. Okay. So we have a case scenario. 57 years old patient, female, presented with non-productive intermittent cough for 2 months. There was no shortness of breath, orthopnea, or paroxysmal nocturnal dyspnea. She denies fever, night sweating, or weight loss. She noticed a transient erythematous rash over her shins for the last 6 months. So we can say she's having cough and rash. Cough, 2 months, rash for 6 months. Her medical history, drug and family history are unremarkable. Normal. She never smoked and has no past medical history of exposure to organic and inorganic allergens. Normal body mass index. Normal physical examination, except that the patient is having pallor and JVB is just visible when she is lying at 45 degrees. So the positive findings are she is pale, she have slightly raised JVB. So what do you think this patient is having? If you are thinking of chronic granulomatous lung diseases as sarcoidosis, our case, then you are in a good shape. If you are thinking about other conditions like pneumoconiosis that causes interstitial lung diseases, you are in a good shape. The rash, if the rash is making you thinking about other systemic diseases, then you may think of pneumocystis jiverni, or you may think of rheumatoid arthritis, SLE, inflammatory bowel diseases, but you need more findings in the history and examination to tell you about these disorders. So what we're going to do for this patient, the investigations that we're going to do, we're going to start with chest x-ray, which showed in this patient bilateral pyrolymphadenopathy. This makes sarcoidosis more likely. CBC, which demonstrated normocytic normochromic anemia. We tested the patient for ACE level because the chest x-ray made sarcoidosis, the higher lymphadenopathy in the chest x-ray made sarcoidosis more likely, and the chronic presentation, and she is a female and she's above 50, more likely to have an autoimmune disorder, and her ACE level turned up high. So what we're going to do for this patient next, we're going to biopsy the patient, and the biopsy yielded an noncaseating granuloma, which is a confirmative for sarcoidosis. So getting back to the history, the transient rash in this patient is most likely erythema nodosum. So however, the presence of a caseating granuloma, a noncaseating granuloma with naked epithelioid cells, only a few lymphoid cells, and the biopsy is confirmatory for sarcoidosis. But we have to consider the evidence when we are presented with chest x-ray for the patient. You have to consider what does a patient with chronic cough and erythema nodosum and higher lymphadenopathy means. What are the differential diagnoses in the association with respiratory and constitutional symptoms and bilateral higher lymphadenopathy on the chest X-ray? The suggestions are interstitial lung diseases, tuberculosis, sarcoidosis, or lymphoma. So these are the 4 differential diagnoses. So this is the normocytic normochromic anemia. If you look carefully, you will find the RBCs normal in shape, normal in size, normal in hemoglobin concentration or the color of the hemoglobin, normochromic. So you have to understand that we give the patient with sarcoidosis is treated by steroids, nothing else. And as we said, the rash is most likely erythema nodosum. The differential diagnoses are interstitial lung diseases, tuberculosis, sarcoidosis, and lymphoma. For a patient with constitutional symptoms, respiratory symptoms, bilateral lymphadenopathy. 3 triad of constitutional symptoms, respiratory symptoms, and bilateral lymphadenopathy in the chest X-ray suggest these 4 differential diagnoses. So you have to keep in mind that pneumocystis jirovecii may be a secondary cause as in a patient with HIV, and it presents with erythema nodosum and higher lymphadenopathy and pneumonia sometimes. So, but after we investigated the patient more thoroughly, we found that ACE inhibitors is high, and this is more suggestive of sarcoidosis, and TB is still a possibility. So we have to exclude tuberculosis. So pneumocystis jirovecii, pneumonia must be kept in mind. Then we have to exclude TB, because even if the angiotensin converting enzyme is high, it does not mean it's only sarcoidosis. It can also still be TB. So after you become very suggestive and suspicious of sarcoidosis from the history, and even after you've done chest X-ray and you've done AC level, you still have to exclude tuberculosis. This is a very important point. You have to keep it in mind. But if you did a biopsy and the biopsy showed that there is an noncaseating granuloma, then you confirm sarcoidosis. You only exclude TB if you really suspecting this patient is having TB because the patient is having a high risk, because he's working in a home shelter, he's working in an overcrowded area, or so he's a poor patient. So sarcoidosis is a multi-system granulomatous disease. Multisystemic, it's a granulomatous. The reason is unknown and affects individuals worldwide, and it's characterized by the presence of noncaseating granuloma that involves multiple organs. So multi-granulomatous, unknown etiology, involve multiple organs. Lungs are predominantly affected. Other organs like eyes, musculoskeletal system, exocrine glands, reticuloendothelial system, heart, kidney, CNS, skin are often involved. So it's basically overall the body. So it can involve the skin, eyes, CNS, kidneys, heart, and so. Most of the cases occur in adults, like before the age of 40. So 20 to 39, and the incidence may vary throughout the world, because for example in the United States the lifetime risk is less than 1%, and it may be higher for black people. It's more than 2%, and the mortality range from 2 to 5%, so it's 2.5%, and usually due to respiratory failure. So the incidence and the frequencies varies according to the place, according to the race. So these are the numbers, and this is the mortality rate, and this is the main reason of death. Okay. Talking about the pathophysiology of this disease, it remains unknown, but researchers suggest that sarcoidosis is initiated by autoimmune response to multiple environmental risk factors. Sometimes people are genetically susceptible. The development and accumulation of granulomas is the fundamental pathophysiology of sarcoidosis. So, a susceptible patient who is having the risk to become affected, a susceptible patient who is having abnormalities in his genes, making him more probably to have the disease if he exposed to environmental problem in the presence of environmental risk factors. The patient may develop immune response that create the disease. So this is the main process. This is the hypothesis behind the sarcoidosis, and the disease process itself appears to be moving around formation of granuloma, and the granuloma formation is the main reason why symptoms occur. So the granuloma generally form to confine pathogens. So in the normal people, when there is an inflammation, granuloma occur to hold down the spread of some pathogen spread and restrict the inflammation and protect the surrounding tissue. But here in the situation of sarcoidosis, there is abnormal granuloma response, and this the initiating event is even unknown, and the presence of CD4 cells that interact with the antigen presenting cells and help to form and maintain the granuloma is a cardinal feature of sarcoidosis. So there is a CD4 cell. When we say CD4, we mean T helper cells, which interact with, or we mean B cells, which interact with another CD4 cells, which is antigen presenting cells, which may be the macrophage or T helper cells, and it maintains the chronic inflammatory response. And this is the cardinal feature of the granuloma in sarcoidosis. You will find CD4 positive cells in the granuloma, and you will find giant cells that are fused together and they form epithelioid cells. So when inflammatory macrophages and polymorph nuclears, they fuse together, when they fuse, they form either epithelioid cells or Langerhans cells. So giant Langerhans cells or epithelioid cells. The epithelioid cell is a giant cell that lost its phagocytic function and becomes secretory, and it maintains the inflammatory process. So this is a characteristic feature of sarcoidosis. We will see it in a microscopic slide a few slides away. Or in the next slide, I mean. So this is the granuloma. You can see there are multiple inflammatory cells here and here, and this is the center of the necrosis, and there is no caseation. If there is a caseation, there will be a necrosis, necrotic tissue. There is no necrotic tissue here, so there is no caseation, and the central cells here, they called epithelioid cells. They are giant fused inflammatory cells, and they have mainly secretory function. And the lymphocytes are in the surroundings of the center of the granuloma. So you can see the demonstration here in the next picture. Langerhans giant cells in the center, surrounded by epithelioid cells. So this is the Langerhans cells, surrounded by epithelioid cells. So sarcoidosis may present in either an acute or chronic manner. It can be acute, it can be chronic. Most patients may have constitutional symptoms or specific organ involvement. So it can be acute or chronic. There may be constitutional symptoms or specific organ symptoms. 4 possibilities. You have to know that 1/3 of the patients may present with arthritis, erythema nodosum, polyarthritis, or just fever and bilateral hyaline-lymphadenopathy on chest X-ray, and this is known as Lofgren syndrome. So the Lofgren syndrome is polyarthritis, fever, bilateral hyaline-lymphadenopathy, and chest X-ray. And you have to keep in mind that the lungs are involved in 90% of patients, and patients present with dyspnea, cough, vague chest discomfort, and abnormal sounds. Okay, so some cutaneous manifestations like maculopapular eruptions and erythema nodosum, they may be associated with acute sarcoidosis, while with chronic sarcoidosis there's something called lupus Bernio. So we have here 90% dyspnea, cough, chest discomfort, wheezing, cutaneous malformation, maculopapular eruption, erythema nodosum, and in acute setting is erythema nodosum, while in chronic setting it's lupus Bernio. So we will see lupus Bernio in an image, we will see erythema nodosum. What do you think this is? If you are thinking erythema nodosum, then you are in a good shape. It's a painful, hard, raised babule in the dorsum of the foot and in the interior surface of the leg. And this is a lupus Bernio. And when we say lupus Bernio, we are talking about specific cutaneous manifestation of chronic multisystemic sarcoidosis, and it was first described back in 1889 by Bessiner, someone called Bessiner, and it's very common in African, and it's hyperactivity of mediated immune cell. It's hypersensitivity reaction, and epithelioid cell granuloma without, characterized by epithelioid cell granuloma like what we previously demonstrated, which is devoid of caseous necrosis. So there is no necrosis in the granuloma, and usually upper respiratory tract and lung involvement appear to be present in some of the cases. So we're gonna demonstrate this lupus Bernio in an image, so you have to be careful. It looks the same in most patients, but sometimes it becomes more harder and more prominent. So here you can see it's called lupus Bernio, and it's specific cutaneous manifestation of multisystem sarcoidosis, and it was discovered in 1889, and its hypersensitivity reaction and it's characterized by granuloma, noncaseating granuloma. Okay. So other extrapulmonary manifestations of sarcoidosis is uveitis, which is inflammation of the uvea of the eye and is the most common ocular manifestation of sarcoidosis. CNS manifestation may vary with isolated transient 7th cranial nerve palsy, may become Bell's palsy, so it's a differential diagnosis for Bell's palsy. When we say 7th cranial nerve palsy, we mean the facial nerve. There's something called cranial nerves which are exiting from the cranium, the skull, and they are numbered from 1 to 12. And when we say 7th cranial nerve, we mean the facial cranial nerve, which is the cranial nerve that supplies the facial muscles and control the facial expressions and the taste of the anterior 1/3 of the tongue, and control the secretions of parotid gland and other salivary glands. So, and control the stapes muscle in the ear. So the 7th cranial nerve, when it's injured and there is a lesion in the nerve that is not known, or sometimes due to herpes simplex, we name it Bell's palsy. So in the setting of sarcoidosis, isolated 7th cranial nerve may be isolated 7th cranial nerve lesion may be present, and this is a differential diagnosis for Bell's palsy. Sometimes the patient may have optic neuritis, which may lead to blindness and eye pain, inflammation of the optic nerve, which is the first cranial nerve, and sometimes the patient may have infiltration to the pituitary gland, lead to hypopituitarism and hypothalamic hypopituitarism, and sometimes may develop diabetes insipidus, which is dia mean through, beatis mean dia mean through, beatis mean urine, so through urine. So insipidus means acute onset, so diabetes insipidus, acute onset of loss of fluid through urine, and this is a condition occurred due to the loss of ADH. So this is central diabetes insipidus or cranial diabetes insipidus. Sometimes cognitive decline may occur and meningitis may occur. So we said uveitis is the most common. You have to know that CNS manifestations may be isolated 7th cranial nerve palsy, Bell's palsy, and optic neuritis, hypothalamic hypopituitarism, cranial diabetes insipidus, cognitive decline, and meningitis. So carefully assess the patient for lymphadenopathy, large lymph nodes, and palpate the organs for the abdomen for organomegaly. So you may find a large liver, and it may be found in 40% of patients and 20% of patients respectively for lymphadenopathy and hepatomegaly. And you have to understand that splenic enlargement with hypersplenism may result in pancytopenia. So when you do CBC, you may expect pancytopenia because they are enlarged spleen and hypersplenism. So lymphadenopathy is very common. Hepatomegaly occur in 20% of patients and hypersplenism may occur. This is how uveitis looks like. So you have to know that sarcoidosis have many extra pulmonary signs and symptoms. The first, we will say cutaneous. The second is lymph nodes. The third is ocular. The fourth is hepatic. The fifth is splenic, cardiovascular system, and CNS, renal. So these are the extrapulmonary manifestations of sarcoidosis. The most commonly affected organ is the liver, 20 to 30%, the prevalence of conditions. of extrapulmonary manifestations of sarcoidosis is 20 to 30% in the liver. It can reach 30% in the ocular system, but it may be as less as 10%. It may reach 20% in lymph nodes and renal, but it may be as low as 5 to 10% respectively. So you have to know that the highest prevalence in the liver and the ocular system. Each system involvement have its specific symptoms, and each system have specific investigations that is done for it. So when we are talking about cutaneous, the investigation must be biopsy. When we are talking about cutaneous, the investigation must be biopsy. Lymph nodes, the investigation must be biopsy. And for the ocular, the investigation must be systemic ophthalmologist assessment. And for the liver, spleen, it must be CT scan. For the cardiovascular system, it must be ECG, echo, MRI, and so. For the nervous system, it must be MRI. For the renal, it must be systemic renal test and biopsy. And the symptoms, as we said, for the spleen it is splenomegaly, for the liver it's hepatomegaly, and for the ocular system is anterior, posterior uveitis, vascular hemorrhage, and lacrimal glands enlargement. And in the cutaneous system it's lupus brino and subcutaneous sarcoidosis and erythema nodosum and so. And in the nervous system is facial nerve palsy. And as we said, look at this table, it will give you a good summary. I will keep it for a while. Look at it. You will notice that the highest prevalence is in the hepatic and the ocular. Okay, and the cutaneous lymph need biopsy, and the abdominal need CT, and the brain need MRI, and the cardio need cardiac testing, renal need renal testing, and the ocular need ophthalmologist assessment. So I think it's clear. How do we diagnose sarcoidosis? You have to know that 1/3 of the patient to 1/2 are asymptomatic and only diagnosed on routine chest X-ray. So when we are talking about symptoms, sarcoid, acute, chronic, 10%, say 50 acute, 50 chronic. 10% of this 50, 10% mean 5%, 10% of these 50 are asymptomatic, while 90% are having cough and so. All these, to the half of them, are asymptomatic. So 90% of acute sarcoidosis is symptomatic, while half of the patients, of all the patients of sarcoidosis, are asymptomatic. Chest X-ray are classified into 4 stages. Stage 1, bilateral hilar adenopathy. Stage 4, fibrotic bands, bullae, hilar retraction, and bronchiectasis. So you can see here hilar lymphadenopathy, very obvious and clear, and it have many differential diagnoses: TB, sarcoidosis, aspergillosis, silicosis, and pneumocystic Javernine pneumonia, and so. Another X-ray showing the classification of the disease. Look at look at stage 1 x-ray. What do you think this patient is having here? He's having sarcoidosis, but what do you think the finding is? We said that stage 1 is hilar lymphadenopathy. So bilateral mediastinal hilar lymphadenopathy is evident in this chest x-ray. There is nothing else. This is suggestive of stage 1 sarcoidosis. This classification described in the 19th century by something called Washoe Committee. 0 is normal. 1, so patient with sarcoidosis having normal chest x-ray. This is stage 0. So how do you know the patient is having sarcoidosis? The patient is having high angiotensin converting enzyme and having evidence of granulomatous noncaseating granuloma. So he is not having hilar lymphadenopathy, normal chest x-ray. This is grade 0. 1, there is a hilar lymphadenopathy like this image here. Why stage 2? You can see here. What do you think of this chest x-ray? If you are saying adenopathy and pulmonary infiltrates, then you are in a good shape. So still the patient is having lymphadenopathy and he's having infiltrates. The chest x-ray is infiltrated. So we will go to the third stage. And what do you think? If you are saying only pulmonary infiltrate without, there is no hilar lymphadenopathy, only there is pulmonary infiltrates, so you are in a good shape. And the fourth stage, what do you think about it? If you are saying hilar lymphadenopathy, pulmonary fibrosis and infiltrate, you are in a good shape. So the diagnosis requires clinical suggestion compatible with chest x-ray and histological specimen for the diagnosis. Transbronchial biopsy to obtain a histological specimen has a low risk when it's done by an experienced hand. So we do clinical investigations, we do history, we take history, we do clinical examination, we do chest x-ray, we do angiotensin converting enzyme level, and then we take a biopsy. If you are still suggesting and considering sarcoidosis. So similar granulomatous conditions should also be ruled out. For example, if you are taking a transbronchial biopsy, we may take some tissues and culture it and aspirate it and culture it for pneumocystic giverni if you are dealing with a patient that is having HIV or is at a risk of having HIV. Note that when we are dealing with Love-Green's syndrome, a biopsy is not mandatory, as a diagnosis is reasonably clear. The patient with fever, arthralgia, hilar lymphadenopathy. And in patients without obvious pulmonary involvement, we can do PET scan to assess possible involved site for biopsy. So we demonstrate the involved site first to do biopsy. So when biopsy is refused or it was inconclusive, we can do immunological testing. If we found that CD4 to CD8 ratio is greater than 3.5, normally CD4 to CD ratio is 2 to 1. So if it's greater than 3.5, highly abnormal, it's 94% specific for sarcoidosis. If it's negative, it means nothing because it's only 53% sensitive. But if it's positive, it indicates sarcoidosis. In the setting of this clinical scenario, just X-ray abnormalities. Then we can do serum angiotensin level. If we found it twice greater than twice normal, and we found an enhancement in the parotid gland and lacrimal glands, this is called Banda sign. So it's supportive for the diagnosis of sarcoidosis. Another option, we can do biopsy. But if we don't have a suitable site for biopsy, and the patient who is presenting to us do not need immunosuppressive treatment in the next 4 weeks, we can do something called Kivium-Silsbach test, which is a test like tuberculin test, Silsbach test. So we inject sarcoid tissue and intradermally, and then biopsying the babule that develop within 4 weeks. So if the patient is not needing an emergently to be treated by immunosuppressive, we can inject sarcoid tissue and we can assess him after 4 weeks if we cannot biopsy him. Okay. Once the diagnosis is done, pulmonary function test must be assessed, and sarcoidosis is usually pure restrictive or sometimes is mixed. So we do pulmonary function tests, and we have to do ECG, liver enzymes, renal function, calcium for other extrapulmonary manifestations. So diagnosing criteria of sarcoidosis: first, we need clinical findings. Second, we have to rule other diseases. We have no alternative disease, we have no any sign and features and confirmatory test positive for other infections. We have evidence of noncaseating granulomas. So the three are present. Then sarcoidosis symptoms, we excluded other diseases. Typically special findings, we have extrapulmonary findings, we have abnormal chest radiograph. So all these factors lead to sarcoidosis. So we have three. You have to understand that we need clinical findings, no alternative disease, and evidence of caseating granuloma. So we are talking about the sarcoidosis symptoms. We excluded other diseases. We have typical findings like Love-Green syndrome or by asymptomatic by hilar lymphadenopathy. This is sarcoidosis. In the setting of exclusion of other diseases and typical special findings like Love-Green syndrome or by hilar lymphadenopathy, this is sarcoidosis. If we have extrapulmonary findings plus abnormal lung chest radiograph plus exclusion of other diseases, this indicates sarcoidosis. So how do we treat it? We use glucocorticoids, steroids for 6 to 24 months, chronic treatment, but as many patients with sarcoidosis are incapacitated due to the disease, careful weighing of potential benefits versus risk of steroid therapy is essential. Some patients are very sick, so they may deteriorate with the treatment. We need to assess the benefits and risks before giving the patient the steroids. So the dose depends on the organ involved. Okay? And lung involvement necessitate high dosage, but cutaneous eye and cardiac sarcoid require less amount. Cytotoxic drugs like methotrexate, azathioprine, and immunomodulators may be considered in a patient with poor response to steroids. So we give steroids. This is a period, and the dose dependent on the organ. And if we are talking about failure of steroids, we give cytotoxic medications. And before giving steroids, we have to make sure that the patient is having no peptic ulcer. We have to check the renal function of the patient as a baseline, You have to make sure that the patient is having no depression or psychosis. Most of the sarcoid patients have a natural course of self-resolving disease, which is resolved 2 to 5 years after the diagnosis. So how we gonna assess the protocol? There is a group of patients in whom the disease tends to run a chronic protracted course. So we need to reassess our protocol for the treatment when the patient is becoming progressively ill. What we're gonna do, chronic patients can be identified at presentation by risk factors. We're gonna assess the patient earlier, and we're gonna consider whether this patient is we're gonna anticipate whether this patient is going to develop a chronic disease or not. So how we gonna know that? Risk factors like fibrosis on chest X-ray, presence of bone cyst, so stage 4 sarcoidosis, bone cyst, cardiac neurological involvement, requirement for systemic therapy within 6 months of the diagnosis, or the presence of renal calculi. So these are 6 things. Except for neurological diseases, you exclude isolated 7 cranial palsy. If anything of these are present, this indicates and you can anticipate the risk of chronicity. So when a patient is having fibrosis, bone cyst, neurological diseases except 7th cranial nerve, requires systemic therapy within 6 months, and renal calculi which indicate hypercalcemia, which occurs in sarcoidosis. There is hypercalcemia. We can check calcium level because there is a high production of parathyroid hormone like peptide and vitamin D from the granuloma. The granuloma of sarcoid is having 25 alpha hydroxylase and 1 alpha hydroxylase, which produces an activated vitamin D, and the activated vitamin D increase the calcium level, and the increased calcium level will lead to calciuria, hypercalciuria. This leads to stone formations. So the presence of high calcium indicates the activity of the granuloma, the activity of the disease. Patients must be monitored for a minimum of 3 years after cessation of treatment, and long-term therapy to prevent recurrence may be considered. No indication for antituberculous unless there is specific diagnosis of tuberculosis. And co-treatment for pneumocystis jiverni is not indicated unless there is a diagnosis of pneumocystis jiverni. So, to conclude the session, we will say that sarcoidosis is a multisystem granulomatous disorder of unknown etiology. There is evidence that it is initiated by an immune response from multiple environmental risk factors and is in genetically susceptible individuals. Mainly it involves the lungs in 90% of patients. Eyes and skin and liver are commonly affected sites. ACE level is elevated band and lambda signs on the gadolinium scan, and immunological testing and bronchoalveolar lavage are suggestive but not diagnostic of sarcoidosis. Suggestive. You have to understand that histological demonstration of noncaseating granuloma is mandatory for the diagnosis except in few special scenarios like Love-Green syndrome and asymptomatic hilar lymphadenopathy. It's classified into 4 stages via X-ray, and it's self-limiting in most individuals and do not require treatment. And when treatment is required, we use steroids. If it failed, we use cytotoxic agents. Generally, acute sarcoidosis tend to have a good prognosis, while chronic sarcoidosis have a poorer. The patient who is presenting acutely may present very ill, but he have a good prognosis. And the patient who presents chronically may present well, but he have a poorer prognosis. Thank you. I hope it was clear and nice.